Is this a hospital or is this a prison? Like, seriously, what are we doing? Let me set the stage. So a version of this has happened to me at least 100 times, hundreds of times, but this was just a month ago. I was in the middle of a really difficult conversation. The patient was only 40, and I'm the one tasked to tell her about the metastatic cancer. And my phone rings for the third time in 5 minutes. Yeah, I know, don't bring your phone into the room when you're breaking bad news. I know that. I forgot it was in my pocket. But now it's ringing, and it's from the resus area. Hard to ignore, so I answer it. I instantly regret it. Can the patient in bed 23 drink some water? For God's sakes! Yeah, I might not have been in the best emotional state to field this phone call at that exact moment. But are you really asking me if a grown human being is allowed to eat and drink? Are you really asking me if a sick patient who is thirsty is allowed to drink some water? What kind of bizarre prison are we running? Of course they're allowed to drink. This is a human being we're talking about. I've been talking about some version of this topic for a pretty long time now, right? The early myth to tackle was that patients need to be NPO before procedural sedation, and I think we've done away with that. But I think there is a much bigger issue here. It's way bigger than procedural sedation. I think it is time for a much bigger cultural shift. I think we need new departmental rules. I think we need to bring nursing, anesthesia, surgery, everybody on board, because it is time that we treated our patients better. Welcome back to First 10 EM. Some patients are better than others, but it's pretty much similar everywhere that I've worked, right? My phone rings constantly. I get this question multiple times every single shift. Can this patient drink water? Can this patient eat? I've seen nurses arguing with patients. I've actually, in my career, seen a physical confrontation as a result of a nurse telling a patient not to eat. And there was absolutely no reason to keep that patient NPO, but the nurse was following what they thought were the rules. Eating and drinking are core human activities. They are a necessary component of being healthy. And yet, for some reason, like every emergency department has this blanket baseline ban. For some reason, we make emergency departments more miserable than they have to be. How the hell did we get to this place? How the hell did this insanity start? Patients are human beings. Let them eat. And I'm going to go through some of the evidence to back this claim. And there will be a full write-up on first10em.com. But before we get into the science, I think it's important to take a big step back and just think about the logic that underlies our current status quo. The practice of keeping patients NPO, or nil by mouth, if they were going to go to surgery, dates back to 1946. There was a paper published by Mendelssohn in which 66 women had aspiration events during obstetrical anesthesia. And over the next decade or so, you see multiple citations and publications, and that sort of morphed into this recommendation that anyone going for surgery should be kept NPO. And that quickly morphed into the idea that anybody with any chance of going to surgery, and so basically like everybody who's undiagnosed in the emergency department, should be kept NPO. Now we're going to get into some modern numbers, but we often forget about the denominator in medicine. So there were 66 aspiration events, but that was out of more than 44,000 women. Too often we focus on antidotes. We forget about the numbers. We forget about the denominator. So the real aspiration rate here was only 0.15%. And most of these aspirations did not have severe long-term consequences. This cohort is actually worse than most that you'll find in the published literature. 2 patients did die. And we do not want to downplay the real harm here. 2 young women died. And we need to consider that. But it was 2 out of 44,000. We need to remember the denominator. So the real harm is a lot less than 0.1%. Mortality was 1 in 22,000. So let's start by assuming that this is actually a good idea. Let's assume that having a patient's stomach empty at the time of induction of general anesthesia is a really good idea, and it's going to prevent that 1 in 22,000 risk. How does that risk apply to the average emergency department? How does this translate to our rules that exist that keep everybody NPO unless specifically granted permission by the doctor? How many patients that you see in the emergency department go to the operating room the same day? I mean, even truly surgical conditions like appendicitis, hip fracture, this will depend a little bit on geography around the world, but most of those go to the operating room the next day, right? I've worked in 4 different countries, and all those things, surgery the next day. My department right now sees more than 300 patients every day, more than 2,000 a week. How many go to the operating room the same day? The torsions, the open fractures, the perforations. I'm not even sure that for my hospital, vascular and neurosurgical stuff counts because we have to transfer those. And by the time I make the phone call, get them in an ambulance, send them out, they've had 4 hours of NPO time to get them out of my hospital. I'm not sure the exact number. It's about 5 or maybe 10 at most every week who go for same-day surgery and therefore might benefit from an NPO policy, if there is a benefit, and we'll get back to that in a second. So we're starving more than 2,000 patients for the sake of 5 or 10. And remember, the risk of aspiration is less than 1 in 10,000. So at 10 patients a week going for same-day surgery, for example, we would need to starve everybody for 1,000 weeks in a row for a single patient to benefit. 19 years of starving every single patient in a busy emergency department for a single patient to potentially benefit. If it's only 5 patients a week, we're talking about 40 years. 4 million patients starved to prevent one aspiration event. And worse than that, how many of those 10 surgical cases really actually want to eat? How many of them need to be forced to stay NPO by a rule? Right? How many emergent brain bleeds have you seen asking for a sandwich? How many intestinal perforations are trying to get a cheeseburger? Right? The rule doesn't help most of these patients. So the benefit is way lower. It might be 10, 20, it might be 50 million patients starved to prevent one aspiration episode. So when you're making a decision, you can't just focus on one side of the coin. You can't focus on benefit without harm. There might be benefit in 5 or 10 patients a week, but the flip side is that we are starving 2,000 other patients. We're causing dehydration. We're causing conflict between patients and nursing staff. Patients miss important regular medications because they're told they're not allowed to swallow anything. Doctors are constantly distracted by pointless phone calls. So before I've even touched the evidence, even if we assume that there's actually a benefit from starvation, from NPO status, the idea of starving every patient for 20 to 40 years with all the harm and conflict that policy entails just to prevent a single aspiration, it doesn't sound like that logic is very good. I think it's pretty clear the logic behind this whole idea of keeping every emergency department patient NPO. It's very, very flawed. But let's talk about the evidence, because unfortunately things get a lot worse. Because that entire logic, everything we just went through, is based on the idea that there is a benefit from starving people. And it doesn't seem like that's true. In fact, it looks like it's the exact opposite. In all the evidence that I can find, starvation, and I can't believe I have to say this out loud, but starving people is bad. But let's back way up. Let's start with some basic physiology. So this graph, hopefully I can get it up on screen here, shows liquids leaving the stomach. And there's tons of dogma out there, but the real science is that the only thing that really seems to influence the speed of liquids leaving the stomach is calorie count. So milk is the same as juice, is the same as pop. Water is basically entirely out of the stomach by 30 minutes if you drink a large glass. The soft drink is the green line on here, and basically it's gone by an hour, maybe 90 minutes at the latest. In fact, the most important thing that I came across in all the literature that I read is that the stomach empties exponentially with the amount of volume in there, which means that adding liquid to the stomach increases gastric emptying. So if you have somebody who just finished a large solid meal, their stomach will be empty faster if you make them, if you force them to drink water, than if you leave them NPO. Drinking water leads to an empty stomach faster than keeping patients NPO. Drinking is probably protective against aspiration. Now, it's hard to get perfect number for solids, and the harms of solids are much higher when they're actually aspirates. So we need to be careful here. But unless you're engaging in some kind of 4th of July hot dog eating competition, if we're talking about a reasonable meal, you can expect 90% of solids to be out of your stomach by 4 hours at the latest. And I took a conservative number there. I think there's lots of data that will tell you a reasonable sized meal is actually out of your stomach, gone by 2 hours or so. And I think that makes sense, right? Just think about what we do everywhere else in medicine. We don't give activated charcoal to a poisoned patient after 1 or 2 hours because we know that patient's stomach is empty. It's not going to do anything. So why is the patient's stomach empty so quick in toxicology patients, but not in surgical patients? It just doesn't make sense. But of course, that's not true. It's the same. 2 hours is probably a good average for stomach emptying for solid content. So basic physiology tells us that our current rules don't make any sense at all. But what about some clinical data? So we've known for a long time that NPO status is irrelevant for procedural sedation. We have the ACEP guideline that tells us do not delay procedural sedation in adults or pediatrics in the emergency department based on fasting time. Pre-procedural fasting of any duration has not been demonstrated to reduce the risk of emesis or aspiration when administering procedural sedation and analgesia. There's another full blog post on First 10 AM about this. There are thousands of patients in the published data, and there's absolutely no association between fasting time and adverse events. The data confirms what we already know. Aspiration is very rare. The number that comes up is about that 1 in 10,000, and that's 1 in 10,000 in unfasted patients. But I think too many people get too focused on just the number, the rarity, but that's not the major conclusion here. Yes, it's true, it's rare. Almost nobody will aspirate. But more than that, the data suggests that your aspiration risk is the same, whether you've been fasted for 1, 2, 4, 6, 8 hours. Aspiration risk does not change with fasting time based on the data we have. So in the emergency department, fasting does not matter. Do you think that elevator ride to the next floor somehow changes the fundamental rules of physics or biology? Do you think the results are going to be different in the operating room? Of course not. And there's actually a lot of operating room data, and the OR data is the same. There is no data that exists that shows a benefit from fasting. There is a ton of data that shows harms from fasting. In fact, I think in emergency medicine, we might be stuck in a little bit of a bubble. And maybe this is a North American thing as well, because when I talk to anesthesia friends in Europe, in Australia, in New Zealand, this is just normal practice. They think we're ridiculous. They let people drink until 1 or 2 hours before surgery. That is standard practice in 2024. But for some reason, in the emergency department, we act as if a single sip of coffee is like a cardinal sin. So let's talk some data. There's a 2023 Cochrane review that found no difference between a 2-hour fast and a standard fast. Gastric volumes, pH, aspiration rates were all the same. In fact, this is so well known in the surgical literature that essentially all the research now, from anesthesia at least, over the last decade, is looking at even shorter fasting times. They now just assume that 2 hours is the standard. 2 hours is the standard care group, and modern research is looking at shorter times than that. So the protocols from anesthesia are often called sip till send. Let the patient keep drinking until they're actually called to the operating room. And we have observational data now with tens of thousands of patients. They have fasting times as short as 17 minutes, and they have seen no harms, no increases in the risk of aspiration. But in fact, it's not a neutral change that we're talking about. And this shouldn't surprise anybody, right? Eating and drinking are core human functions. But letting people eat and drink has all sorts of benefits shown in the literature. There are the obvious benefits, right? Patients are happier when you let them eat and drink. There's less thirst. There's less hunger. Patient satisfaction goes way up. People don't behave their best when they're dehydrated, right? How many of our angry patients in the emergency department are just hungry or dehydrated? How many patients leave AMA just because we have these stupid rules? Honestly, this is one of the dumbest slides I've ever created. Of course, starving people is bad. But then there are all sorts of other benefits on top of just, being a good human being. There are trials that show that decreased fasting leads to less perioperative hypotension, less acute kidney injury, less insulin resistant, less hypo and hyperglycemia, less delirium, fewer surgical complications, fewer wound infections, and I've even seen a study or two with a hint of an association with lower mortality. I'm not talking about some fancy new drug here, right? These outcomes are better than almost anything we prescribe. Like across the board, better outcomes. And all we're talking about is letting human beings do a basic human function. Just let people eat and drink even when they're going for surgery, and they have better outcomes across the board. Our entire logic for keeping everybody in the emergency department NPO was based on the idea that we were helping a handful of patients who needed surgery. We were willing to accept the harm of starving everybody because maybe there was a big enough benefit in those headed to surgery. But it turns out that strict fasting is harmful even in patients going to the operating room. I'll say that again. Even if the patient is headed to the OR in 4 hours, there is still data that strict fasting is going to be harmful to that patient. Even if they're scheduled for the OR, the data says that at the very least, they should be allowed to drink. Now, I'll point out a pretty major gap in this data. Almost all of the OR data has really focused on decreasing liquid fasting while leaving the solids at 4 or 6 hours. And that makes some sense based on the physiologic data that I talked about. On the other hand, we have pretty good procedural sedation data that shows that there is no association at all between fasting and aspiration risk. So I think all we can really say at this point is we don't know. But every single one of us in emergency medicine knows how to manage the airway in unfasted patients. I literally have never intubated a fasted patient in my entire career. So if a patient really needs surgery, we know that the benefits outweigh the risks. We can intubate these patients, even if they're not perfectly fasted. If there's a need for surgery, that's what RSI was created for. If the patient needs surgery, there is no doubt the benefit dramatically outweighs the risk, which we know is far less than 1 in 10,000. In emergency medicine, I think we do a lot of things because we're trying to help out our colleagues, right? I order that ANA, even though I have absolutely no idea how to interpret an ANA test, because I'm trying to help out the rheumatologist. And sometimes that's really nice, but other times it can lead to massive miscommunication. Like honestly, I don't think that most anesthesiologists understand what we are doing to our patients. We're making massive assumptions about what they want, and we're hurting our own patients as a result. And I think there's a very good chance that our assumptions are incredibly wrong, because the anesthesia guidelines make it very clear that these patients should be allowed to drink. In fact, not just allowed, but encouraged. The American anesthesiology guidelines don't just allow clear fluids until 2 hours before surgery, but they specifically say that we should be encouraging drinking because we cause way too much harm by over-aggressive fasting policies. They allow a light meal up to 4 hours before surgery. European guidelines say adults and children should be encouraged to drink clear fluids until 2 hours pre-op. Canadian guidelines again say encouraged. Adults should be encouraged to drink until 2 hours pre-op. Children should be encouraged to drink until 1 hour before surgery. I just think about your standard surgery consult in your department. How long does it take to page surgery? Get them to call you back. Have them come downstairs, assess the patient, write some orders, and eventually transfer the patient upstairs. Even if the patient is going for same-day surgery. If we're supposed to be encouraging drinking until 1 or 2 hours before surgery, right? That's what the guidelines tell us. So until surgery has been formally consulted and the patient's actually scheduled to go to the OR, all of our patients should be encouraged to eat and drink. That isn't fancy evidence-based medicine practicing out on a cliff. That is the current guidelines that are actually probably too conservative. There is never a reason, based on our current guidelines, for a patient to be NPO prior to the diagnostic workup being completed. There's one emergency department in America that I saw that changed their policy to just that, just follow the ASA guidelines. Solids allowed until 6 hours pre-op, so they got rid of the NPO at midnight order, and then clear fluids were allowed until 2 hours pre-op. So not the evidence we were watching, but the guidelines. And so I think those guidelines are a little bit too conservative, but even with that change, just following the current guidelines, there were dramatic effects. There were no harms at all. But there was a big decrease in nursing frustration, decreased patient thirst, decreased complaints about hunger, better glucose control, decreased overall workload for nursing staff, fewer phone calls to the doctors. This change is literally better for everybody in the emergency department. Patients, staff, everybody. So guidelines, logic, science, they all say the exact same thing. Let them eat. The historical practice of depriving patients of the basic necessities of life just in case has clear, significant harm with no benefit. The risk is minuscule. The risk of a real aspiration is less than 1 in 10,000, and it's not clear at all that fasting decreases that risk at all. In fact, every bit of data we have suggests that fasting has no impact on aspiration. Now, we shouldn't take the aspiration risk lightly. We shouldn't be encouraging patients to eat quadruple cheeseburgers while waiting in the emergency department, sure. But the benefits of patients eating and drinking dramatically outweighs that 1 in 10,000 risk, right? It's not even close. First of all, there's just, basic human decency. Our patients will be happier. There will be less conflict between patients and staff. How about withdrawal? How many people watching this video could function without a coffee in the morning? Why are we demanding our patients in the emergency department to forego the same? That's crazy. On top of that, you'll get less distractions, less phone calls about whether a patient is allowed to eat or drink. And then there are a host of medical benefits: less dehydration, less missed medications, less hypoglycemia. The science, the logic is incredibly clear. Let them eat. In fact, no. That's not nearly strong enough. Do not just let them eat. Encourage them to eat. And then leave it up to doctors to identify that small minority of patients who really should be kept NPO. The rule should be that everybody eats unless there's a very specific physician order to the contrary. And then be very careful about your order. The anesthesia guidelines tell us that the historical NPO at midnight is very harmful. Patients should be encouraged to drink until at least 2 hours before surgery. So the appropriate order for basically everybody being admitted to surgery is probably clear fluids, basically every time. Although, honestly, that's a bigger change. I'm not here to change surgical practice, even though I think that's probably the correct answer. I just want to change our practice, change how we treat our patients in the emergency department. And luckily, that's really easy. In the emergency department, before another service is consulted, unless the doctor specifically writes an NPO order, the rule is incredibly easy. Everybody is allowed to eat and drink. No, not just allowed, encouraged. Everybody is encouraged to look after themselves, to stay healthy. Encouraged means installing easy-to-access water machines around the waiting rooms. Encouraged means signage. Encouraged means installing vending machines that actually have edible, healthy options that don't cost more than double the minimum wage, right? It is time for us to change. And if we do, this isn't just going to help our patients. This is going to make all of our lives dramatically better. Fewer angry patients, fewer phone calls, healthier patients. This is literally a win, 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 win. So that's it. That's my argument. That's the science. That's the logic. And I think both the science and the logic are very clear. I don't think science or logic will be our problem here. Unfortunately, culture gets in the way of science over and over and over again in medicine. So I would love to hear from you all. I'd love to hear your success stories. Tell me about times that you managed to change culture in medicine. Get in the comments. Tell us about how you changed this culture in your hospital. Share your success stories so other people can follow in your footprints. So I think together we can make our lives better. We can make our patients' lives better. That is worth the effort. Until next time, take care.